everyone. It's our final session. Sad. Hopefully you've achieved everything you'd hoped to achieve this week. For those staying on for the weekend, I think there's snow on the way towards the end, so cross your fingers for that. Pretty cruisy afternoon today, so we just have 2 presentations, so we'll probably be able to get you guys a little bit of a longer tea break, won't have to have everyone rushing around too much, and then of course we'll get you guys out of here so you can quickly have something to eat and then get ready for the closing party at Wellstar. Photo competition as always, so definitely get ready to start your cheering for that one. But first up, we'll have Brandon chat to us. So I'll call Brandon up stage to kick things off for this evening. Let's hear it for Brandon.
Hey everyone, that would have been really funny if I fell up the stairs. So, I just want to introduce myself quickly. My name's Brandon. I am a nurse practitioner in the Aeromedical setting. So I do retrievals. I also work within the emergency departments in Brisbane in Queensland. So that's my basis. Now, let's have a quick sticky beak of what we're talking about today. So I called my presentation from Flight to Flow, Rethinking Aeromedical into Hospital Transfers. So very simply, we're looking at the patient's journey from the start, when I pick them up at the little small rural hospitals, and take them down into the more metropolitan facilities. How we can improve that journey for them, and more importantly, how we can improve it later on throughout the ED. That's what I'm really interested in patient flow. As I said, nurse practitioner in Aeromedical, work in ED as well. So I'm really interested in bridging clinical gaps and looking at system efficiency. So improving everything from flow. So I've previously done research in patient pain relief and how we can improve patient flow utilising analgesia. I'm also doing some research at the moment on this topic, looking at 2 aspects. One, where patients land within the ED versus the ward. And then I'm also looking at doing further research into how much time they spend in ED and how it affects everyone. So how long paramedics spend with them, etc. We'll go into that a bit longer. Drop something. So, what we're going to expect today, quickly running through everything. So, we'll look at the context of the problem. So what actually occurs, what the literature tells us. We'll talk about my study that I'm currently doing and where it's at. We're going to run through 2 little case studies. One looking at the emergency perspective from when I've done a shift of triage and a patient that's come in on an IHT. We're going to look at another case study from an aeromedical perspective where I've been stuck ramped with a patient. And then we're going to discuss some solutions on how we can fix this. We're also then going to look at some further research that can be done that I'm doing. And then what this applies to us and what we can be doing now to improve this. If we have time, we'll look at questions. So to appreciate the scale of the challenge, it's worth looking at the numbers. Last financial year, Retrieval Services Queensland, so they're the company that manages all retrievals without Queensland, had approximately 26,000 aeromedical transfers across the state. That's quite a lot. That number is continually growing year on year, so it's not a shrinking problem. These transfers are crucial as the state is so large. We've got many areas with very limited primary health clinics, very limited help that can be done for patients, so we need to move them to more tertiary centres to get just scans. A lot of these facilities don't even have an X-ray available. So, these transfers, so they involve planes, they involve crews, so pilots, nurses, they involve the teams at Retrieval Services Queensland, they involve all the clinicians for patients to arrive at, and it's just quite large. So traditionally a transfer wouldn't proceed until both a ward and an accepting doctor were confirmed. But recent changes known as the Green Light Protocol have removed that bed requirement. Now, a patient can be transferred based solely on clinical acceptance, even if there's no bed immediately ready. While this helps reduce delays in transfer initiation, also introduces new complications, primarily where and how that patient is received on arrival. Often, that patient will just sit in ED waiting for that bed to be available, causing more ramping that we don't want. At the heart of the issue is a tension between the two priorities. Clinically, we want transfers to happen as soon as it's safe. So the little rural facilities need those patients to get out as soon as possible. Operationally though, the receiving hospital needs to be ready. If they don't have a bed ready, that patient just sits in ED. That causes that misalignment and not the best outcome for the patients. This is worse and exacerbated during the after hours when admitting teams may not be present and patients end up funneled through the ED. This isn't necessarily wrong. Some patient needs to go through ED. Think of your really sick person that deteriorates or your undifferentiated patient that's come from an ED regionally. But it also reflects misalignment, as not all patients do need to go to ED. You've got a patient that's sat on the ward for 2 days, 3 days, waiting to go to a tertiary facility for an operation. Why do they need to go to ED? So these decisions really matter. They set the trajectory for patient care, impacting the healthcare system more broadly and the patient's journey directly. When a patient is transferred from one ward expecting to go to another, but instead boards within the ED, we create disjointed care. The patient stays in the ED when they would initially expect and have the expectation that I'm in a ward, I'm going to go back to a ward. Quite often the nurses at the sending facilities will explain to the patients that, hey, we've got a bed for you available, we're going to go send you there. Then they get ramped in the ED. Quite often on an ambulance stretcher, which I don't know how many have sat on an ambulance stretcher, but they're not very comfortable. Emergency department boarding occurs when patients have been admitted but remain physically in the ED because there's no inpatient bed available for patients and are unavailable to be moved for other clinical reasons. This is not just a logistical issue, it's associated with worse outcomes, including increased mortality and longer length of stay. In the context of inter-hospital transfers, boarding takes on new significance. These patients are often accepted with a clear plan but end up delayed due to downstream bottlenecks, particularly in after-hour scenarios or capacity surges. In Australia, we use the 4-hour NEAT benchmark as a core performance metric, and ED boarding directly undermines this. Studies show that once ED length of stay exceeds 4 hours, patient outcomes begin to suffer. This isn't just theoretical delays in imaging. Analgesia, CAM plan initiation, and handover all contribute to poorer experiences and higher risks. For IHTs, patients who've already been managed at another location, prolonging their care and stretching the resources when they don't need to be. Another challenge is a redundancy. When a transferred patient arrives through the ED, even when a known diagnosis and plan, the ED teams often repeat assessments, rechart medications, and replicate documentation. Sometimes because it's required, other times because of system fragmentation. These duplicated efforts consume clinical time unnecessarily and contribute to workflow congestion. Literature confirms that even many inefficiencies, when repeated across high volumes, erode clinical capacity. Previous research in pain relief has shown that patients that receive more than 2 tests have a longer ED length of stay when not necessary. Let's not forget about the patient. They're who we're here for in the end. So the patient experience, imagine being moved from the ward to from a stabilised ward to the busy ED with little curtains covering you all up. It's not very nice. And then you're stuck there. Or even worse, you don't have curtains. You're stuck on the ambulance stretcher ramped. The patient will often feel forgotten, uncomfortable, or even question the quality of their care. Studies show that poor patient experience correlates with reduced compliance, greater anxiety, and disengagement from the care process, all of which undermine both outcome and satisfaction. Aeromedical transfers introduce unique physiological and psychological stresses, changes on the patient, oxygenation, changes in pressure, oxygenation, noise and motion. Some patients arrive more unstable than expected, prompting cautious routing through ED. That's appropriate when clinically necessary, but sometimes it's driven by communication gaps. For example, if in-flight observations or concerns aren't clearly relayed during the final handover, this increases the chance of unnecessary ED delays. Finally, the literature shows a consistent theme. Time of day matters. After hours arrival face longer ED waits for ward teams, greater reliance on generic admitting doctors and fewer decision makers on site. This reality drives many after-hours IHTs into the ED by default. Not because of deterioration, that's fine, but because the system isn't equipped to receive them directly to the ward. These patterns create pre-detectable inefficiencies that need to be addressed at the system level. This is what I'm studying at the moment. So the current study we're doing is the disposition of IHTs in ED. So against that backdrop, we initiated the dispositions of aeromedical transfers into hospital transfers in the ED. My goal is simple: to understand what actually happens to patients after they've transferred. Yes, we're all quite certain assumptions on this. I know I had assumptions prior to starting of what these patients and how long they sit in ED for. However, there's no data out there to represent what actually happens. There was one study published in the Philippines which wasn't very comparable. So it looked at the average wait time of 16 hours in ED. I don't know, in Australia and Queensland we don't have 16-hour wait times on average. So we need to create some data and literature to support change in Australia. So for our study, we've designed a retrospective study drawing on 4 years of linked data from 3 core sources: Retrieval Services Queensland, the Emergency Data Collection, and the Queensland Health Admitted Patient Data Centre. This allows us to track the patients from referral through the retrieval services to ED arrival and into inpatient care or discharge. Importantly, the dataset spans 2 key policy eras. The first 2 years of the data, prior to the green light process being put in, and the second 2 years after, which enables us to see what effect it's actually had on those patients. The dataset includes demographic and clinical info like age, sex, diagnosis, transfer priority, level 1 to 5. It also has timestamps for referral, arrival, triage, discharge, and admission. What we're especially focused on is the disposition endpoint. So whether that patient goes to the ward, or if they stay in the ED, or if they're discharged altogether. These outcomes will tell us a lot about whether the ED visit was clinically justified or merely procedural. Results are yet to be finalised, we're still collecting all the data. But based on early trends and published literature, we're expecting several things. A notable portion of patients will board within the emergency department, despite this not necessarily being required. Thus, increasing ED length of stay for both the boarding patient and in turn all other patients in the ED. We suspect time of day, modality, such as fixed wing versus rotary versus road, including handover utilised, weekday versus weekend, influence whether patients board in the ED or proceed directly to a ward. Identifying these predictors is key for future process reform. So, a little bit more exciting, other than all the literature we've been talking about. Let's talk about some patient studies. So from a hospital perspective, let me share a real-world example that I've dealt with at triage. So I was working in a tertiary centre in Brisbane, and I was seen at triage. About 0200 one night, a renal calculi came in from, not to name, but the well-known Harvey Bay that always sends renal calculi to Brisbane. They had a mild hydronephrosis associated. The patient had been sitting at the hospital for 2 days prior to coming, so already on the ward, sitting there comfortably, coming down to get blasting of that zone in Brisbane. The patient had been receiving IV antibiotics for the hydronephrosis. They'd also had analgesia and would have been nil by mouth from midnight, which, you know, is 2 a.m. So the nil by mouth. At triage, I went above and beyond, as I would. So I went above and beyond. I called the urology reg myself, and I was like, look, I've got this patient, they've arrived down to us. Are you happy if they go directly to the ward? There was a ward bed available, even better. And like, yeah, totally fine, happy for that. The patient just needs these things charted up. It's like, no worries, we can arrange one of our ED doctors to do that. Our ED registrar on for the night shift, just appropriately so, called the surgical registrar. That'd be the one admitting the patient on the ward. And the surgical registrar's like, oh, I'm in theatre, I'm not going to be able to review them for the next 4 hours. Please keep them in ED until I can see them, I'm a bit concerned. There was no clinical concern, the patient had good observations. Anywho, as a lot of EDs are of a night shift, we were ramped all night long. So this patient sat on the stretcher with QAS till 6 a.m. when the urology reg came in and was like, why is my patient in the ward? I said they could go. Urology reg saw them and said, yep, cool, let's get them to the ward. So they went to the ward at 6 a.m. Was that necessary for QAS to be sitting in the ED for 4 hours with that poor patient ramped? I don't know, I disagree. What can I say? I'm not a doctor. I didn't make that decision. So, another case study. So this time I'm going to look at it from an aeromedical perspective. So, recently I transferred a 16-year-old patient requiring mental health admission from a regional facility to a tertiary facility. This patient was having a psychosis secondary to withdrawing of her medications of her own volition, with some, you know, homicidal, suicidal thoughts, as all good 16-year-olds do. She'd actually spent 48 hours sitting in the respective ED because they were unable to manage her in the ward, being a mental health patient, them not having any mental health capacity. During that 48 hours, she absconded once and took some more Panadol when she was out, not requiring any treatment for that. When we eventually got to pick her up after that full 48 hours in the ED there, we flew her down, not needing any management in flight, unfortunately. I love giving mental health patients ketamine in flight. They sleep so well. Anyway, so she was unsecured, we didn't need anything. However, she's already proved herself to be a high flight risk, this patient had. So on arrival to the receiving facility, again, middle of the night, she had a bed available, being a mental health bed, they're always available on arrival. However, the psych reg wanted to review the patient. As a lot of us ED folk know, we know that psych regs are very, very busy of a night shift. They see multiple patients and psych reg wanted to review. So we waited on the QAS stretcher in the ED for the psych reg to see 2 hours later. I waited with the patient because obviously they're a mental health patient, so we need to stay with them. This delay in transfer enabled me to collect the next patient. We needed to collect that night, so I had another patient lined up, which we had to cancel due to flight hours, instead of this patient going directly to the ward, with already a confirmed plan and treatment overnight. Again, delays for the ward cause a backlog of extra patients. Issue that, you know, we probably should look at fixing. So what solutions can we look at and how can we improve this? So I believe we need to change the framework and the thinking that we've currently got towards IHTs for this. So if we look at the governance and communication, so appropriate disposition decisions require structured governance and effective communication. Currently, the referring clinicians have the predominant input with the receiving clinicians, not changing too much of the plan until patient until patients arrive at the receiving facility. However, emphasis of the transfer planning should include the referring and the receiving clinicians, as well as the nursing teams involved, equally reducing the unnecessary ED stops. So in other words, if everyone decides on it together, why can't we have plans already written? Why can't the receiving team go, you know what, that's our plan, I'll have it written during daylight hours. So when that patient arrives, we already have a med chart written. We already have an interim plan written. They go directly to the ward as long as the patient's stable and continue with that until they get their formal admission. So, as I've just said, the simplified plans. So we're going to look at implementing these sort of strategies, but we just need that evidence at the moment to support it. So tactics such as med charts written, plans already done during business hours. This will not only relieve the teams when the patient arrives, it'll relieve the ED clinicians from having to go, that's fine, I can write these up for you. And it will also relieve the night shift admitting doctors, because I know that they are always run off their legs. I don't know many med registers who will not be admitting the patient over night shift. It is the job they do. Another opportunity is to extend the role of the experienced retrieval teams. So to help with deterioration that patients may see. So quite often a patient in flight will get increasing pain. Aircrafts rattle around, they increase in anxiety due to the noise. It's uncomfortable, an aircraft stretcher. So if retrieval teams can utilise aspects such as nurse-initiated analgesia, because communication is very, very hard on a sat phone. You have 2-3 words and a 10-second delay before you get an answer back. It's very difficult to go, my patient's in pain, can I please give this? If we can nurse initiate medication, we can improve that in flight, which makes the patient more stable on arrival. Additionally with that, so handovers, quite often we aim is to reduce handovers when we're in a hospital. But so a retrieval team will often hand over to the paramedics. That's one handover. The paramedics will hand over to the triage nurse. That's 2 handovers. The triage nurse will write information to hand over to an ED nurse. 4 handovers. ED nurse will hand over to a ward. 5. What if the retrieval nurse, or at least the paramedics, hand over directly to the ward? We are reducing many handovers in that situation, reducing the risk of miscommunication and, suboptimal care. So the idea of ED reaction is we are improving the patient safety and outcomes. However, as we've already gone through in the literature, that's not the case, as it increases ED length of stay. But the idea is that, these patients could be sick. It's just a nurse on the flight. Most retrievals are just a nurse on the flight. So, they could have missed something, the patient could be deteriorating. So why are we keeping that patient in the ED? There's no great clinical reason, unless they were unstable, which will be escalated, I would hope, by the teams. So having that, ED is the safe option, isn't always the best option. So based on literature and my own clinical experience, and I can assume all of your own clinical experience, several operational themes emerge. Governance frameworks must be strengthened, especially around out-of-hospital hours admission. Clear escalation pathways should exist for when ED review is clinically indicated. So if we establish, these vital signs were unstable, that's when they need to go to ED, rather than they are stable, they don't have to go to the ED. Just changing that thought pattern might improve that process. But then we also need that case-by-case flexibility, obviously. So, after my current study of the dispositions, we're then looking at a timed study, so a time in motion study. So this time in motion study, we're actually looking at the staff time utilised. So we're going to look at the paramedics, how long they spend with that patient. we're going to look at the nursing staff, how long they spend with the patient, i.e. how long it takes to triage, how long they spend if they sit in ED, because any time in ED shouldn't be happening. We look at how long the admin staff, because then that can put a cost figure onto how long that patient being in ED is affecting the healthcare system. Cost savings equals more staff. So that study will be beneficial in actually promoting to the decision makers of the department and go, you know what, we can save hundreds of thousands a year by reducing these patients into the ED. So this study, we're looking at utilising an observation at 4 major facilities across Queensland. We'll collect data of 1 month windows to control for seasonal and temporal variation. We're going to track all of these numbers and have them all there to create variation and evidence, really. We aren't going to include ward staff in this though, as the thought pattern is that that should be the standard. These patients should be going to the ward, so why include the standard in the study? We expect the data to confirm with what many of us already sense, that ED pathways involve more tasks, more handovers, and more staff time. Conversely, when patients are transferred directly to the ward, the admission process tends to be faster, more predictable, and less duplicative. We're also exploring whether time of day or transfer modality influences workflow burden. These insights will help build the case for broader adoption of direct ward to transfer frameworks. Ultimately, our aim is to quantify the system-wide benefits of reforming IHT workflows. Even modest time savings when applied across hundreds or thousands of transfers free up clinicians for direct patient care. Reducing duplication helps ease burnout, improves documentation accuracy, and improves patient outcomes. Most importantly, aligning the admission process with patients' needs rather than system defaults supports safer, more respectful care journeys for the patients. So, what can we do about this now? There's not much literature out there, but what can we do? So, as ED clinicians, this research highlights that not all IHTs need to default to ED care. If a patient is stable and their needs are already well defined, consider advocating for ward admission directly, especially if you're working after hours, and know that the pathway isn't aligned with patient needs. Escalate to admitting teams early and where possible. Become part of the discussion to reshape your own local admission policies. Retrieval clinicians and paramedics have an essential role in the patient journey, and your voice matters in shaping what comes next. A structured, clear handover supports safer and faster ward admission. But beyond handover, retrieval and transfer teams should be involved in the feedback loop and post-transfer reviews to help flag inefficiencies and missed opportunities. The goal is shared governance, not just task completion. To the policymakers and leaders, if there's any in the room, finally, this is the call to action. Good governance must be grounded in operational reality, and that means listening to frontline clinicians. Investment in linked data and real-time feedback systems, clear escalation protocols is essential. Our studies aim to provide insights, but it's leaders who must turn that into system change. Without the change, it won't happen. So to wrap up, the Disposition of Aeromedical into Hospitals Transfer study is helping us understand what really happens to aeromedically transferred patients, while the timed IHT study will help quantify the hidden workload that comes from avoidable ED routing. Together, they provide a foundation for clinical and operational reform. We know transfer disposition isn't just a tick box. It's a critical pivot point that affects outcomes, experience, and efficiency. Let's ensure it reflects real patient needs, not systematic defaults. I'd now like to open the floor to any questions. If anyone's interested? No.
Thank you very much, Brandon. If anyone does want to touch base with Brandon, I'll dob him in now and say feel free to come have a chat to him in the break or at the end of the session. Let's have a bit of a break. Just before you do, you might see a few QR codes lying around. They're for our feedback forms. So before starting these conferences, Dylan and I have never actually been to a conference ourselves. And the whole premise behind it was like, well, it's a conference, what do we want? But it shouldn't be what we want, it should be all about what you guys want. So please, any suggestions you have, any ideas, please use the free text at the bottom there as well to share them, because we're really open ears and just wanted to, I guess, continue doing conferences that we love to go to, but also you guys love as well. So if you do have a moment, that would be much appreciated. Let's take 5 minutes and then we'll finish things up with Tim. All right.
I think on this side, if you need. It's pretty dark.
I'll ask him if he's using the slides up properly.
What's that? What about now? Still pretty dark. Under the lower. I need to shift this. It's there. Grab some for the kids. Maybe grab 2 or 3. What's happening with this?
That's not using. Alrighty team, it's time for our final prize giveaway. We've got 2 shirts left. I think we've got 7 entries today. So you guys hopefully all know the deal by now. Let's see them. First one. Yeah, 3 people liked it. Hey. It's always tough going first. Alright, next one. Good work. We've got a clear standout winners at the moment. Christmas in July. I feel like it's just the same people. Oh, there we go. Top of Ben Lamont. Very nice. Yeah, I think that's worthy of applause. Hopefully they made it down.
That was a video.
Oh, it's a video. What's that? Alright, let's hear it one more time for the person who Oh no, this is Dylan! the ice cream? So good. We may have gone there a few times. I was wondering why he sent those on through a bit late. Oh, there's the one. Alright. What do we reckon? We've got 2 prizes. I'm thinking... Plankers? Oh, I wonder who said that one. Yeah, plankers, alright. Plankers, we'll go with that one. And I reckon... Jeez, what do we think? Yeah, Christmas in July? Christmas in July, sorry guys. Alright, Christmas in July and the plankers if you guys want to see Dylan at the end. We'll get you guys some t-shirts. So one more round of applause for everyone who was part of those photos. Alright, I'm very excited now to have Kim join us up on stage. I think this might be Kim's 6th, 5th?
I've lost count, actually.
She's featured many of our conferences and is always a great person to have and sort of, I guess, shed light on all things mental health, and she's done lots of different topics for us in the past. So one of the great things about Kim is that she's always happy to take questions as well. So if you are listening, have any questions as we go, please make sure you shout out. And let's give Kim a nice round of applause to kick things off. Thanks, Kim.
So Quentin always keeps me to time because I tend to absolutely go off time. So mental health is my passion. I've been a CNC in mental health for, it makes me feel old, over 36 years. I'm not going to say the exact amount. Botox is a wonderful thing. So I actually met my friend Maria on the flight over here. So my daughter, who's also a CNC and one of our co-responders, is normally my scribe but couldn't come. So Maria, who's a psych reg, is actually going to help me out, which is lovely. So Maria's from West...
I'm from
Metro North. There you go. So she's going to help me out. So today's going to be a bit of interaction. There's no role play, so don't panic. I'm not going to make you do a role play. But I suppose mental health is there. Mental health is not going away. So for us as first responders, ambulance, ED, doctors, nurses, we need to be aware of mental health. We can put in place all frames of ED avoidance, but you know what? There's still going to be mental health that's going to come in, and we need to be aware about it. So quicker. So I'm actually a QPS co-responder. So I might just ask in the room, because I wasn't here for the opening night, so can you put your hands up if you are an AMBO? Great. Who's an ED doctor? Nurse? Allied health? Anybody that specialises in mental health? Maria. I met her on the plane. So I suppose, as I said before, mental health is there. We can try and put in our place in QS, ED avoidance, but after hours, it's a safe place. We know there's limited bulk billing doctors. Lots of mental health patients cannot afford to go to a doctor. Lots of mental health patients are, there's low socioeconomic. They're not in a place to go and see a doctor to get that mental health care plan. There's a waiting period for psychologists. There's a waiting period for psychiatrists. So how do you get help? It's a really difficult field to be in. How do you get help if you're in distress? So if you fix this, please. So just that one? Big press. So that's a bit about me. We don't need to go into that. Okay, something's wrong. Okay, so when Quentin and Dylan contacted me, and I do thank them because I am passionate about mental health and I do appreciate the sponsors. I thought long and hard. And do you know what I thought? Maybe it's a time to have a refresher around mental health. So when I speak to my staff, I like to roam too, so I'm sorry. When I speak to my staff in ED, they often say, why doesn't that ED nurse know what to say about an MSE? Why doesn't that AMBO need to hand over properly? Well, you know what? If we don't learn it constantly, how do we know it? So I say, you know what? Here's an ECG, read it for me. And they can't. So unless we have refreshers around what we need to do, how do we know, how to, impute that information? So food for thought. This is a quote I love. So it's mental health problems don't define who you are. They are something you experience. You walk in the rain and you feel the rain, but you're not the rain. Does anybody relate to that? Like, it's mental health doesn't quantify who you are as a person. We can all experience mental health, yeah? And we all have the risk of experiencing mental health. So we need to take that in mind when we're seeing our mental health patients. There we go. So I just, Gold Coast Health, we're a little bit different, okay? So we like to think outside the square. So lots of services have their QAS, QPS, ED avoidance. We think about it a little bit differently on the Gold Coast. So it's not just about avoiding people coming in. So they get a proper assessment. They get a CNC assessment for mental health. If they need to come in, we bring them in. We've already done the full assessment. Nobody has to touch them again. We go straight to the consultants who know us. We tell them what we want. We tell them what we need. We ring the bed manager. If they need to be admitted, they get admitted. There's no medical clearance for us, which I think is different to a lot of other states. Why should we have medical clearance? What is that about? So somebody's distressed and they wait for hours, because they will wait for hours. So they're distressed, nobody goes near them, nobody tells them what's going on, so the distress rises, yeah? And then they become a problem. So we have lots of services that we implement at Gold Coast, and I'm not going to go into them all. You can read it up there. We're always looking at what we need to implement. We're always thinking, what's different? What could we do differently? What could we do that provides that patient-centred care, that trauma-informed care? And that's another talk that I do, is about trauma-informed care, because you need to know about trauma-informed care. So we know from an ACEs study, you know, if you experience 6 or more adverse childhood events, and that could just be a parental separation, it could be something simple like a parental addiction, 6 or more, you're 2,000% more likely to experience suicidal ideation when you're an adult. That's huge. So we need to put more care into our mental health patients. I'm just going to fast forward through that. So I like to be interactive, as I said, and it's not about role plays, but it's about getting you guys thinking a little bit, because it's the last session. You're ready to go and drink. It's the closing party. So I'm going to get Maria up. So I want you to think, how would you define mental health? And I want you to raise your hands. Everybody knows what mental health is. You've all experienced with your patients. How would you define it? What is mental health to you guys? There's no wrong answer. Come on, guys. Psychosis, absolutely. What else are we experiencing with psychosis? Hallucinations, yep. Drug-induced psychosis, absolutely. So intoxication, when I work with the ambulance, is a big part of what we see. But we also know, and Maria is an addiction specialist as a psych coach, the more drug-induced psychosis you have, the more chance that you are likely to develop an enduring mental illness, like schizophrenia. We know that. So we have them come in, we discharge them saying they're sober now, push them out, but unless we link them with the right services, what are we doing? We're just putting a band-aid on the situation. So what else? What else is mental health? Come on, guys, I know you know the answers. Anxiety, absolutely. Absolutely. So I even hear my staff that go, it's just anxiety. You don't know how that person feels, because anxiety can be debilitating. So there's anxiety and there's anxiety. So you need to suss that out. Yeah? What else is mental health? Bipolar, yep, absolutely. So mood disorders? Yep. What else, guys? You see it all the time. Suicidal ideation, absolutely. Yep. So we have this gag in Risutsu. So my children always say to me, if you watch back your videos, Mum, every time you say absolutely, it's so many times. So we used to have a drinking game in Japan. So every time I say absolutely, everybody has to scull a drink. But we're not going to do that today. But anyway, bit of a gag. So what else is mental health? Depression, absolutely. Yeah. There we go. If you had a drink, you need to scull. Yep. Do you think these things are rising? Yeah, they are. Absolutely. We'll get to that in a minute, why they're rising, but they're rising. So we can try and put in place how we treat this, but there's always going to be people that you're going to go out to as AMBOs that are coming into the ED. How do we treat it? We don't want to bring people in with just run-of-the-mill because we cause more distress. We know that. Yeah? What else is mental health? Addiction. Yeah. What else, guys? Personality disorders. And they're hard, aren't they? We all don't like our frequent presenters that are personality disorders. You know, they really drive us, you know, to the point that we go, oh my God, they're back again. Yeah? But they're not doing that on purpose. They don't come in, I always say, they don't come in saying, I'm going to stuff up Kim Lappin's day and I'm going to make her suffer. Yeah? They're in distress, they don't know how to deal with it. So what else? What else is mental health? Trauma. Trauma's a big one. Thanks, Maria. So how would you define recovery from mental illness? If you think of it, think of yourself. How would you define recovery? What does recovery look like from mental illness? Functioning. Yeah. Yeah. What else? If you think of a family member that was suffering, what does recovery look like? Because often we just think they're a patient, but think of it if this was your family member, and that's what I always say to my staff, blue sky thinking. If this was your family member, what would it look like and what would you want? So what is recovery?
Establishing like a new baseline that's hopefully as asymptomatic as possible.
Yeah, yeah. So establishing a baseline, so getting back to normality, like, yeah. So you'll hear us in mental health, we call about, you know, patient-centred care, recovery focus, trauma-informed care. These are important words, and they mean something to the patient who is getting our treatment. So it's not just words, they really mean something when you speak to the patients. Anybody else with anything around recovery? Stability. Absolutely. So if you have a drink, you can have a little bit of a sip there. Yeah, stability. You know, and validation. We all want to be validated, don't we? If we're distressed, do we want somebody to tell us we're stupid? No. We want somebody to hear us. Yeah? We want to be heard. We want to be validated. And that's important as a human being. That's our human rights, is it not? To be validated. What we are experiencing is what we're feeling. It doesn't come about somebody else telling us we're wrong. Yeah? So we look at the World Health Organization. So if you look at the definition, so a state of mental well-being that enables people to cope with stresses of life, realise their abilities, learn well and work well and contribute to their community. Does everybody agree with that? Would that make a good statement for, yeah? Okay, and recovery. It's a mental health recovery that goes beyond the absence of disease and symptoms. We all don't want to be labelled, do we? We don't want to be labelled. And we label our patients every day. You know, I hear it, you know, when I hear people say it's such and such coming back again. Well, why are they coming back again? What are we not doing that's helping them? And recovery is a complex continuum that varies from individual to individual. So no two people are alike. We can't label people. We need to look at that person and look at what it is for them that they're not coping with in life. And it's multidimensional, as you know, that sums it up. It's covering all aspects from a bio, psychosocial and spiritual health. So we know this. So if we look at the latest studies from the World Health Organization, the National Survey of Mental Health, we know that people from 16 to 85 in the last 12 months, I think it's currently at 21%. I would say it's getting higher. And I'll go into that in a minute why it's getting higher. So 1 in 5, or a bit more, will experience a mental illness in their life. So if you look at us in a room, so it's 1 in 5, yeah? So we need to decrease that stigma around mental health. It's 1 in 5. It could be a family member, it could be yourself, you know, it could be your sister, it could be your brother. And if we look at the 3 most prevalent disorders that we see, and somebody mentioned it before, it's anxiety disorders. Now, I'm not just talking about generalised, a person that's just not coping. So when we get called out by the ambulance, it's somebody that's absolutely not coping. So I often hear my staff go, it's just anxiety. Well, to that person, it's more than anxiety. There's a reason why they're not coping with that. Do they not have any coping skills? We need to look further. Why is that person not coping with what's happening to them? Affective disorders like mood disorders, depression, and substance use disorders. And we're seeing a lot more of that. When COVID and the lockdown actually happened, it was amazing, and Maria might talk from her understanding, but we saw a lot more people coming into the ED with substance use disorders. And I was amazed how many at that stage were using coke. Before that, you never saw anybody using cocaine. Like, they never said they're using coke, but all of a sudden there was a rise. And I think that linked with their payments. So they had money to buy the coke. And I once spoke to a police officer and said, well, how are we getting in? I'm a bit naive. He said, how are we always getting in? Like, it hasn't gone away. But people all of a sudden have money, and then all of a sudden it's lace. It's not pure coke that they're buying. Yeah?
Can I just want to add, with heroin, we don't have much supply of heroin now, but the other drugs are actually increasing.
Absolutely, yeah. And they're being mixed in backyards. They're being mixed with everything. So when I used to work in addiction scenario, people would say, when I tried to say, look, you're depressed, why don't we look at a medication? They'd say, I don't want to put foreign substances into my body. I'd go, really? How'd you get here? But but it's true, they're going, oh, I'm all natural. But it's about working with that person and looking at a bit of motivational interviewing. Why? Why do you have that belief? Because it's actually stopping you getting recovery. So now I'm going to do another, maybe we can flip it. Bit of a flip. So I want you to think of the populations that you think or you experience have further risk of developing mental illness.
Children exposed to domestic and family violence.
Yep. So children exposed to, domestic violence or adverse childhood events. Absolutely. Yep. And we know that. Yet if you look at how we dedicate our money, so child and adolescent mental health get a really low funding. Yeah? So we know it. Why aren't we putting the money in to do intervention? It's an age-old question. Nobody will answer it. But we can make a difference if we get in early. So what other populations?
Neglect, childhood neglect.
Childhood neglect, yeah. Yep. CSA. Yep. Postnatal depression. Is that what you're saying? Yep. Absolutely. Or postnatal adjustment. Absolutely. So even like the ambos in the room, you might not go out to acute mental health, but you'll go out to emotional distress. You'll go out to acute grief reaction. I've been there. Father's hung himself, he's still dead on the floor, the family are distressed. It doesn't mean it's mental health, but they need assistance. They are not coping. Yeah? So we need to look at what they need. They don't need to come into ED. Absolutely not. But we need to link them. Yeah? Because that can then trigger onto further distress. So what other populations? Sorry? Psychogeriatrics? Absolutely. It's a forgotten field. And if you look at addiction, and Maria might comment on that, addiction in psychogeriatrics is huge at the moment. We forget that. We think they're old. Hello, addiction happens in the psychogeriatric field.
I'd also like to find out the Aboriginals are actually high risk, for mental illness, especially for substance abuse.
Yep.
The low socioeconomic.
Yep.
Uneducated people are very much high risk.
Can you hear Maria down the back? Yep. Yep. So we know our high risk groups. You guys know it. You've been taught it. This is about just refreshing it for you. Just keep in your mind when you see these people what could be happening. And the other question, can you think of specific factors that may increase someone's risk of developing symptoms of mental health? I could name a million, but anyway. What's happening at the moment?
Financial burden.
Financial burden, absolutely. Absolutely. I feel it myself. You know, we all feel it. You know, so how do people cope when they cannot afford to put food on the table? When they're losing their houses? When they're sleeping in cars? You know, what effect does that have? Not only in the parents, but the children. Anything else? Isolation. Yep. And that feeling of not being able to tell people what's happening. That stigma is still there. You know, people associate mental health with, you know, one flew over the cuckoo's nest. Ooh, must be a psychopath, must be a killer. Absolutely not. Anything else? Trauma. Yeah, and we know that. That's what I said before. We've got studies that say 6 or more adverse childhood events is 2,000 more likely to commit suicide. That's massive. You know, we get our alarms raised when we say prostate cancer's gone up by 10%. We know adverse childhood events is 2,000. That's massive. So we know it. Declining physical health. Absolutely, yeah. Yeah. Social media. Yep. And I see it in my young girls, my young children, you know. Everything's about social media. Like when I was young, I'm an ancient, but you know, if you want to get to me, you had to ring the house phone to get my parents and then ask for me on the phone. And, you know, now everything's so accessible, you know. And that's what we see a lot in child and adolescent mental health when we get called out to. It's a lot about bullying, isn't it? It's a lot about not feeling they fit in. It's and when we look at psychiatric developmental point of view, when we're adolescents, peer acceptance is more important than our own family. It comes back. I always say if you've got those family values, it comes back. But that peer acceptance is so important. Yep. And at the moment, people can't get away from that bullying. It's there. They're just getting it, you know, hit by hit. So this is just some of the answers which you guys have answered. So I'm not going to spend a lot of time on that if you just want to have a quick read. But we know everything is linked. You know, it's biopsychosocial. We know the link between physical health, gut health and anxiety. We know the link now between gut health and depression. You know, there's such a link from physical health to mental health. So I want you now to think of the types of mental health disorders you're aware of. What do you see out there? What do you get called out to, or what do you see in the ED? Call it out. Suicidality. Absolutely, yeah. It's a big thing, isn't it? So I often say, and I'm a co-responder, and I am giving a talk to the Clinical Excellence of Queenstown Ambulance the 14th of August around that. You know, it's out there. It doesn't mean everybody has to come in, but we need to wrap around those services. We need to have a proper discussion with that person. Is it true intent, or is it just suicidal ideation? Because there's a difference, you know? Anything else? What other mental health disorders? Homicidal? Yeah, absolutely. You know, people talk about wanting to kill their ex-partner, or, you know, my ex has moved on and how dare that person have contact with my child. I'm just going to kill the, you know, I'm not going to say the explicitives, but we see that. We see it all the time. So when we assess from a mental health perspective, we're taking a lot of risk in looking at that. We're not just dismissing it. What is the risk? Is it low risk? Is it medium? Or is it high? Of course, we're not going to send somebody back out if, you know, they're about to chop somebody's head off. Like, I know it happens. Like the media has portrayed lots of mental health disorders over recent times. But in the event of, you know, you can't be everywhere. You know, risk assessment is for that time in motion. So you can't predict what that person is going to do. As much as we try, you cannot predict it. Any other types of mental health disorders? Somebody mentioned before psychosis. So we see a lot of psychosis with the ambulance, yeah. Schizophrenia, yeah. So they're the ones, you know, if they're acutely psychotic and they're acutely unwell, we want to treat them. We absolutely want to treat them. That's not going away. It's an embedded illness. It's not going to go away because you want it to go away.
Doctors and, you know, for those people who's practicing mental health and even for GPs, the most important aspect would be, you know, to do an actual risk screening In the World Health Organization guideline, there's an acronym called suicidal, and it actually, you just have to take all of that. So you need to actually get, the suicidality, the intent, the plans, the lethality of the plans, whether this patient has got command hallucinations, and what is the command hallucinations actually saying. I had a patient before who said, I plan to actually kill myself, by going to train tracks. And I said, so what are you going to do? And then he said, well, I'm just going to walk there. How can you walk? You actually got pain, in the lower limbs. So I just kept them thinking. And I said, do you have any supports? He said that he doesn't have any supports at home. But later on, I just kept them pushing and pushing, and I found out that he actually, has this, it's like a scooter. And where he lived is actually near the train tracks. So I had to admit him. So when you guys do the restraining, you have to check, what is the risk of this person, to commit that, because at the end of the day, you actually don't want to be involved in a coroner's case.
And that's a really good statement. You have to delve further. So what does that suicide ideation look like? What are your plans? When do you want to do that? Have you thought about how you would do that? And people often say, we don't want to ask the questions because we'll prompt that. Absolutely, you won't prompt that. People often that are suicidal want to talk about their issues. They want to share it. Those people that carry through often will not share it. There are people that will carry through that we never even see in mental health. And I see that often with the ambulance service in Queenstown. When we have deaths, they've never had contact with mental health. So it's weighing it up. But you have to check it out further. And that's what we say when you bring them into ED. Check it out. I once got called out to a bedbound woman. Bedbound. She had a one-on-one 24-hour assistance. She couldn't get out of the bed, and her plan was to lay on the road and get hit by a truck. How? How are you going to get out there? Bringing her into ED was not going to be the answer. So she gets a thorough assessment from a CNC mental health clinician, and she gets linked. There's no point in bringing somebody in that doesn't need to come in. So you need to ask those questions, which is what Maria is saying. So what are the common symptoms? We've named a few in just this discussion, but if you were to look at it, what are the common symptoms you guys see out there? Paranoia, yep. And whether that's drug-induced or whether that's linked to a delusional disorder or to a psychotic disorder or to, a schizophrenic illness. You need to look at that paranoia. Is it reality-based? I've gone to bikies. It's reality-based. They've done the bikie, bad deal, and, it's real. They probably do have a good chance of, getting their fingers chopped off for not paying a bill. But you need to check it out. And they need to be validated on their experience. Any other symptoms you can think of before I move on? Because I could talk for days on this. Sleep disturbance. So we'll get into that in a minute. So that's part of neurovegetative assessment. So when we look at neurovegetative assessment, absolutely. So if somebody's saying they're depressed and they've got neurovegetative disturbance, you need to take it seriously. Yeah? Is that person truly depressed? Different to somebody saying they're depressed and then neuroveg checks out and you're going, I always say mental health is, we're like detectives and you're solving a puzzle because you're bringing that puzzle together and it all has to make sense and you have to ask those questions to then further experience like what that person's going through. So in mental health we use two diagnostic tools. I suppose we use the ICD-10 more, well ICD, I don't know what it is now, 11, 12, anything. Yeah. So when I worked in private practice, we would do assessments on the DSM, but we then also have to do the ICD, codes as well. So in Queensland Health, we use the ICD when we look at diagnostic formulation. So I'm just going to concentrate a little bit on anxiety disorders because there's anxiety and there's anxiety, yeah? And I always say to my staff, you can't just say it's just an anxiety disorder until you speak to that patient because anxiety can be debilitating. And we need to ask those questions. Ideally, we don't want to bring somebody in that's just, a bit of a panic and they're really not coping, if we can link them in with supports. But if somebody's anxiety has gone to the level that they're socially isolating, they're not functioning, they're not going to school, we need to look at that and we need to make those linkages, because that's not going away. It's an anxiety disorder. It's not something they've just drummed up in their mind. Yeah? So that's something to keep in mind. We need to ask those further questions around the symptoms. We have that general apprehensiveness, excessive worry, irritability, feeling on edge, impacts sleep, as I said, neurovegetative disturbance. They're chronic and present for a number of months. So it's not just somebody saying, oh, I got fired from a job, or I've had a fight with a friend, I'm feeling a bit of anxiety and I don't want to go out. You need to have further exploration of what it is. So you need to ask those questions. Mood disorders. So if we look at the full spectrum of mood disorders, so we range from bipolar to depression, yeah? We have BPD and we have BPD type 2 now, which is, I think, is more around the personality components of the person. But in private practice, it's very fancy to get a diagnosis of BPD2 at the moment. Because having a diagnosis of borderline personality disorder, there's a stigma associated with that. We see it. I see people come into the ED and they go, oh, just so-and-so again, they just need a good therapeutic weight. Really? Because they're distressed. So if we leave them without giving them something, that's going to escalate. We're not going to teach them a lesson by saying you can just wait in the waiting room and we're not going to do anything for you. That's not going to work. And if we think of ourselves, if that was us, is that what we would like, or if it was our family member?
For borderline personality disorders, studies have actually shown that, by their 40s, 45, they actually get better if they're modeling something from someone. So in order for you to be able to engage, these patients, you actually have to be developing, this good rapport with them, quite empathic. And then we do have, this better health outcomes where we have GPMP plans, and then link them with a psychologist. Or if you guys want, you can actually do the focused psychological through RACGP, and then you may be able to engage these patients well as well.
Not engaging them is not the answer. They're going to ramp, and they're going to ramp up, and they're going to make you know that you haven't helped them because they're distressed. I always say to people, if I came in and nobody was helping me, I'd let people know too. You're distressed. You're not feeling validated. We need to understand why the person is behaving in a certain way. I always say they don't just come in to our shift and go, I'm going to make your shift shit. There's a reason, and you need to step back and look at that reason. So if we look at disorders associated with stress, which we all see, don't we? That, adjustment disorder, stress-related disorder. I see it in the ambulance all the time. Dad's just died, and I've just cut him down. He's laying on the ground dead, and they're distressed. It's a stress disorder. It is not a mental health disorder, so to speak. But you need to look at then if that continuum increases and presents over time, that then becomes a mental health issue. Then we look at adjustment disorders, which is that maladaptive reaction to the identifiable psychosocial stressor. And also we have PTSD. We all see it. We all, most of our patients have PTSD, don't they? Yeah? And often we then create more trauma for that patient. So they come in, we know their history, we know the trauma, but yet we create trauma. So that's why we often speak about trauma-informed care. It really irritates me when they get sat on the ramp. We call them the blue chairs at Gold Coast. And they're sitting beside a DV perpetrator, and they're a victim of DV. What the hell are we doing? Yeah? What are we doing? We're exposing a DV victim to further abuse. Yeah? So we just need to think. We just need to think a little bit about mental health patients. What are they experiencing, and what are we exposing them to? And then, of course, our psychotic disorders. So we have our drug-induced schizophrenia, schizoaffective disorders, and delusional disorders. it's the one thing I say, you know, when somebody confuses the hell out of you and you're so disorganised trying to listen to the story, there's something in that. That person is disorganised. They've done your head in. You can't even follow their train of thought. You know, you go with your gut. There's something happening for that person. It's not just the stress reaction. There's something more happening. And as we know, schizophrenia is a serious mental disorder in which people lose touch with reality. The one thing I do like to say to people, especially in AD, if there's a visual hallucination, check further. Visual hallucinations do not sit with schizophrenia, okay? And often it will be drug-induced, or you need to look at an organic cause. What is causing a visual? And I can tell a self-story, so I've had shit experience with health lately, so I recently had cardiac surgery. So I was experiencing visual hallucinations, right? So I went to my doctor and said, I've got some visuals and maybe I'm a bit hypoxic, and he said, you need to go see a psychiatrist. I said, absolutely not. I am a specialist in mental health. This is not hypnagogic, not hypnopompic. There is something happening, yeah? And it turned out I was hypoxic, so I had a grade 5 plus PFO, and I was not getting enough oxygen to my brain. So you need to take visual hallucinations. There's something else happening for that person.
So hypnopompic hallucinations can actually happen to anyone. So hypnopompic is when you're half asleep, you know, you try to wake up but you're still asleep, but you're hallucinating. So the way you remember it is P for P, you want to pee, so you're slightly awake.
Yeah. Absolutely. And I can say I can remember all my visuals. They are vivid. And I laugh about them now. You know, I can still remember every single visual that I've had when I was hypoxic, you know. And it was just having good health literacy that I went, this is not mental health. I'm a specialist. There's something more happening. I was under a cardiologist. They didn't pick up I had a grade 5 plus PFO. You know, I went to Rizutsu and another nurse practitioner that actually had a stroke and said, you need to go see my cardiologist, which I did. Had the test, they went, oh my God, Kim, you are absolutely hypoxic. You're not getting enough good oxygen to your brain. So there's your explanation. But any visuals, explore further from a physical perspective. Does not sit with psychosis, and does not sit with schizophrenia. Absolutely, substances will, and I was not using substances, but substances will induce it. But you need to explore further. So if you see somebody that says they've got visuals, explore further. What is happening for this patient? Don't just put them down as being a nutcase or, you know, psychotic. Personality disorders we've sort of discussed. Neurodevelopmental disorders is it's another big talk on its own. But, you know, that's part of what we see as ambulance and part of what we see in the emergency department. And that's a talk in Bali, and it's an 80-minute talk that's very interactive. But if you want to come to Bali, there's a good talk on that. We have our OCD. You know, it's a group of disorders characterised by repetitive thoughts, behaviours, obsessions, and intrusive thoughts. And our eating disorders, we know our eating disorders have raised since COVID. There's research going on around that. You know, it'd be interesting to see what the outcomes are of that. But we know it's increasing. You know, why is that increasing? I have lots of my hypotheses around that, but it's increasing. So we need to be aware of that. Often I bring people in and from an ambulance perspective, we've done our physical and I say, this is going down the line of medical. And then you go, oh, it's eating disorder. And then they do the medical and the person needs a medical admission. You know, you need to do the thorough physical investigation around an eating disorder. And it's not critical to memorise everything, but if you just have in your mind the basics of the main mental health that you might see and the main symptoms, it will carry you well. And that's what I say to my staff when they, as I said earlier, when they say, well, why is ED not, you know, summarising it well, or why can they not do an MSE? Why can't you read that ECG? Pick up the ECG and read it for me. Because we don't refresh our memory from our training, yeah? So how to help? So there's a number of ways you can help. Social support, we often look at that. We need to wrap around the social support for the person. That's the biggest thing. And there's a strong correlation between the person's perceived level of social support and mental health outcomes. If people have nobody, their outcomes are really low, we know that. So how do we wrap around the services for those people that have limited supports? Or how, when we go out and we know they've got supports, we need to bring those supports in. Often people are embarrassed. They don't want to tell their family what they're actually going through or what's happening to them until it becomes this huge, explosion. And then we have to interact. But if we had the stigma released where we say to people, you need to wrap around the social supports. What do you need? We all need it. The outcomes are better.
Can I just say, for people who's got mental illness and they actually turn up in your clinic, there is a 1-300 or some form of number under Sane Australia. You can actually contact them, and then if you have the capacity to be able to get all of these contact cards, to be able to send to your patient. If this patient is actually suicidal, there's also some number that you can actually call on. I guess in the end, mental health, we're mostly bed blocked, and when we admit patients, these are the patients who are actually very, very high risk. So they've got some years, doing that, and most of the time, our GPs are the heroes who's actually, filling in and doing all of the help, to these patients of ours. So yeah, good on the GPs.
Absolutely. And I suppose in Queensland and more Gold Coast, we pride ourselves as the QS and QPS co-responders. We take a step further. We actually make those linkages. Or if they need to come in, as I said earlier, we've done the assessment. We are saying they need to get straight to a bed. We hand over to the ED consultant who knows us very well, and we hand over to our site consultant, and we try and decrease that length of stay, because the length of stay does not help a person in distress. So it's about having the conversation, isn't it? Does everybody feel comfortable having conversations with mental health patients? Yeah. So I often say, just consider that was your sister, your brother, your mother, your father. Have the conversation. I always also say dip your toes in. Don't launch in. It's very harder to get out once you've dived into the pool. So you dip your toes in. Is that conversation going the right way? Yeah? And approach the person in a relaxed, friendly manner, face-to-face, private setting. What I hate is when people come to ED triage and somebody's asking them personal questions. I'm not going to tell anybody at ED triage if I was experiencing some form of trauma. If they can hear me. You need to respect the mental health patient's journey. And ask those open-ended questions. How are you going? Bring up something specific. You haven't seen yourself lately, or your family have called us and they said something is a bit off. Do you experience that? Have that conversation how you would think you would like that conversation. Be prepared to take the time to listen. And I know we're all busy. If somebody discloses something horrific, you don't say, "Oh, stop that." I'm just going to, refer you to something. They've opened up themselves to you. And I know it's hard. I know we're all time poor. But take the time to validate and listen to that person. We've got lots of, as Maria said, lots of linkages out there from GPs to, Are You OK? Black Dog Institute, Head to Health. We know them. So get to know the resources in your area. So if this person divulges something, what can we link them with? The last thing somebody wants to be told is, I don't know what to do. Shit, it's all going pretty bad for you. To know what services are in your area. And rally that support, as I said, from friends and family. That's what people need. They need to feel validated. And be prepared to recognise the person's experiences may be too great. You have to bring them in. If it's too big, you have to bring them in and get further support. And be prepared that person may not want to talk, but you leave it open. We don't bring everybody in that doesn't want to talk. We rule out the risk and we make the linkages. But be prepared. If you knocked on my door, so I did a survey recently, I have to share this. So lots of my health issues and I was feeling really shitty and I was on my Benny Bank app and it had this survey, how do you feel? I went, rah, rah, rah. And then all of a sudden I had all these missed calls. And I got emails. I went, shit, they're about to send an ambulance for a welfare check. I All's good, or just having a shitty day. But you need to be prepared for that. No, not everybody's, rip-roaring, suicidal person or a psychopath. They may be just having a bad day, but rally that support. This is a good technique that I like to use. I've just thrown that pin. So it's the bath technique. Very simple to remember. So background, just ask the broad questions. What's going on in your life? Like what's happening? We're being called out. What's going on for you? And the affect, ask the question, how do you feel about that? That must be really awful. Validate them. Must be a really awful experience. And as I say, dip your toes in. Don't jump in, guns and all, because I'll let you know. And then trouble. What's troubling the most about this? So I can hear that. But what's the worst thing that's happening with this? What's the worst thing that you're feeling about what's happening for you? And then handling. How are you handling this? What coping strategies do you have? Like when this has happened before or, something similar, what have you utilised to help you? And then empathy. You need to validate. It must be really hard for you. What can we do to work together on this? It's just a simple technique where you can just feel you're getting the questions, you're validating the person. Does that make sense, that simple? I know we do it all the time in mental health, we just take it for granted because it's just like, after 36 years, it's just something that we do. But you guys do it well. You guys all do it well. You just underestimate yourself when it comes to it. But if you reflect back, you're doing a really good job with mental health patients. So this is a reflection exercise. So I just want you to, just for a couple of minutes, so I brought in aggression, I could have brought in many things. But when you're feeling really angry, just have a split second think, what's helped you? When you're feeling really angry, what has helped you and what hasn't helped you? Yeah? So just spend a couple of minutes just reflecting on that. You're really pissed off, something really bad's happened, what has helped you to settle, and what do people do that makes you just more irate? And I'll ask you to share some of your, you don't have to overshare, but share what hasn't helped when you're angry. Does anybody want to raise their hand and share? Yeah. I can tell you I was having an argument with my brother in Bali a couple of years ago about, my dad had died and I was caring for my mother. He put his hand in my face. Worst thing you can do to me. Do not put your hand in my face because I will knock you out. Do not. Do not encroach my space and do not put your hand in my face and tell me to stop. So just have a think, because what you think might help you, more than likely is going to help somebody else. Yeah? And if we ask, what has helped you when you're feeling really angry? 15 minutes left. What's helped when you're angry? Breathing, walking, yep. So what do we do in AD? When we bring a person in, often they're detained, what do? We stop them walking, don't we? We stop them moving. So often, and there's a whole other talk on that, but we bring them in involuntary, whether it's on in Queenstown in EEA or involuntary, and we say, you can't live. They go, I just want a cigarette, I phoned for help, what the, F, what are you doing? We need to respect what helps that person. Yeah? Because often if we can intervene early with something that says, what helps you? When you're really riled up, what can I do that helps you? You tell me, and I will try and do it. If I can't do it, I'm sorry, but I will try and do it. So you tell me what helps you. Yeah? I often say to people, some people say a little bit of medication helps just to dampen it, or some people say, just being able to talk to somebody, or, a hot cup of coffee, or we look at sensory stuff, a cup of tea, anything. Ask the person what helps them. So we know aggression, we know we cop it every day, and I'm not saying it's right at all. But most people that are aggressive are frightened, they're scared. If they're paranoid, they're coming from delusions that somebody's going to kill their family, somebody's going to kill them, and you are detaining them. They need to get out to save their family or save their wife, yeah? Take a step back and look at the consumer, and as I said, take just a bit of reflection. What would help you? Maybe it might help them, and ask them. And use the statements, I can understand you feeling that way, and it's okay now to say, I'm sorry. I am so sorry that you've been brought in, but what can I do to help? What can I make things better for you? How can I help? It occurs, we know, because when people feel unfairly treated, they're not validated, they're held against their will. We need to identify. I can say, I often work past the AINs and I say, your patient's about to abscond, and they go, how do you know that? The patient absconds out the door. You can see it. You know, I say to my patients when they're absolutely cognitively full, they can't take any more information on. I can see you're full. You can see it in their eyes. You can't take any more information on. I'm going to leave it there. You know, look at the body language, look at the signs, because they will tell you. And within the healthcare context, aggression, it's not right. We don't deserve to be treated like that, but it happens, hey? And we need to take care of ourselves when it does happen.
Can I just add as well? I just want to add as well, with regards, to the aggressive behavior, if you've got a person who's probably, migrant, and the language is different, then, try to engage someone, like an interpreter, to actually, talk to them as early as possible, because if you've got a heightened patient already, and you both cannot understand each other, then the tendency is you're going to get angry, she or he would actually get more upset. So, just try and think more about, what else to do, because most of the patients who present in the ED, you can talk to them in a reasonable way.
It's taking that time to acknowledge it and taking to a point cultural perspective, as you said. I often see security and they're standing over the patient. Step back from the version. You're arguing with a really pissed patient about the tax, whatever you're arguing about. They're not going to take it on board. Step back. They're going to try, because they're either intoxicated, they're going to try and push your buttons. Absolutely. And so I'm sorry you feel like that. Just acknowledge it. I'm sorry you feel so angry towards me. It's not my intention to make you angry. I think in the old days when I started nursing, we were told never to apologise. You can apologise. It's okay to say, I'm sorry this has happened. This is shit. I agree it's shit. You shouldn't have been brought in. You deserve to be home. Let's try and make that happen. How can we make it happen together? What do you need from me? And it's the words we use. Yeah? You need to first be calm. You can't, and we all have shit days, I acknowledge it, but be reflective. I'm going in to see this patient and I've had a shitty day and my partner's pissed me off. It's not the right time to take it out on this patient. Yeah? So reflect between each patient how you're going to interact. What's their presenting problem? What's the best way to manage them? And we know, and that's why our ED avoidance strategy on Gold Coast, we try not to bring people in. EDs are not the right environment for people that are angry, upset, agitated. Sometimes we have to bring the intoxicated in because it's not safe to leave them out there. But if we have a safe way to leave them out there on Gold Coast, we will. We'll leave them out there as long as there's family that can look after them and it's safe to do so. We don't take risks. We're not going to leave people out there, with nobody. But think about the climate. Think about the environment. Yeah? And our communication strategies. It's not rocket science. You treat people with respect. Dip your toes in. Step back and think, what is it that I would like to be treated? If that was my mum, how would I like her to be treated? I know everybody's busy, but if these little simple things can stop a person escalating and making our shift even worse, we can do it. Recognise the early warning signs, as I said before. I can look at a patient, as I said, and say to the AAN, that patient's about to abscond. They go, oh. How do you know that? They're about to abscond. Because you can see it in their body language. As I said before, you can see when somebody is cognitively full. You just need to look at it. You can see it in their eyes. So you need to be aware of the body language that people portray and look at it and know what's coming next, because it's coming. I saw a patient that used to do push-ups, and she would say, get me that needle, because I'm about to punch somebody. Okay, we'll get you the needle. So it settled her, but you can see it. If somebody's doing push-ups in your ED, they're going to knock you out. Yeah? Done the body language. We'll go past that. And as we said, speaking softly, trying to stay neutral, trying to understand the person is the main thing. Why are they reacting this way? Take a step back and try and understand Why are they behaving in this way? So the one thing I do, and I'm giving a talk to the Clinical Excellence in QS in Queenstown on mental state examinations, it's important to understand why we value a mental state examination. We want to know what the person was presenting like. Okay, it's your perception, not what they tell you, because things can change. So if things change, we need to know that. So you saw the person in this light, and all the levels up there, I'll go into further explanation. But if it changes, we need to know, why is that happening? Why has the person changed? Is it that they feel more settled, they've got support? There'll be a reason. Yeah? So mental health, as I said before, it's a puzzle. It's piecing together that puzzle, and every piece has to fit. And then we make our formulation. It's not just saying, in a 5-minute examination, this is what we think. We pull all the pieces together. We get the collateral, we understand the person, and we try and pull it together to look at what and how we need to treat. Does everybody know how to do an MSc? Yep. Yep. So the more we practice it, the more we get better at it. Because when you're handing over to mental health and ED, we want to know, what was the MSc? What were they presenting like? Because if it's changed, as I said before, there's a reason for that. You know? And the MSc will fit with the picture. If it doesn't fit with what the presentation is, that puzzle's not adding up. You know, if somebody says they're manic and they're presenting as quite flat and depressed, there's no pressure of speech, is it mania? There's something else happening. You know, is it substances? The substances are wearing off. Yeah? So a good MSc is what we really like when you bring somebody into ED, so we can really start to pull that puzzle together. Have we got time to look at that? Probably not. Yeah. So that's another day. It's another story. But it's a really good, if you want to get a look at it, like we often get people to watch the MSc. It's about a manic person and how you pull that MSc together. And risk screening, we want to know that. Risk screening is not just about suicide. Risk screening is about damage to reputation. Risk screening is about, you know, danger to the children. It's more than suicide. Don't just give us this person is suicidal. Okay, so risk the reputation. They're a high, you know, banker and they're, you know, spending money or they're acting bizarre. It's damage to reputation. None of us want to be out there. If I was, you know, clinical nurse consultant as I am and I was running around naked, you know, there's damage to my reputation. We need to take that into account. Mental Health Act, you all know about the Mental Health Act. It changes in every state, but I do really recommend people also look at the Human Rights Act. I know Victoria's done a good lot of work around the Human Rights Act, and we need to take that into account. We should not take the person's human rights away from them. Yeah? If they have capacity, they have capacity. Yeah? Don't just slap them under an order. Because, you know, one day we're going to do that and somebody will sue the arse office. You know, you need to have good grounds. You need to look at capacity. Public Health Act we have in Queensland. I'm not sure if every state has that. So we changed it, I can't remember the year, because often people were being brought in and not just for mental health. So they're intoxicated. It was a delirium. It wasn't mental health, but they get a mental health file. So we changed it to the Public Health Act. If somebody is acting in a way that's putting them at danger or other people at danger, is not just about suicide. I often have the conversation with police when they say, oh mate, he's so paranoid, he's talking about killing his neighbour, I think he's psychotic, but he doesn't meet criteria. Yes, he does meet criteria. Because if he kills that next door neighbour, where do you stand? You saw it.
You can put them under guardianship.
Guardianship, yep, so doctors can in Queensland, I'm not sure about every state, but you can bring in and suggest the Guardianship Act. Just be mindful, when somebody's level comes back to normal, that Guardianship Act will not sit anymore. Once they have capacity, they have capacity. So if you think it's from something else that's causing that, you need to look at your different acts. Because ED will let them walk. The other thing with the EAs, which I often see in Queensland, and I often lecture at Griffith, and they all say in the tutorials, you know, we're going to put you on an EA because that will ensure you get seen. Do not say that. Because that's not true. So you're giving the person false hopes. You know, you need to be honest with people. I think we all want, patients just all want some honesty and to know what's happening. So rather than sitting on that chair for hours and nobody communicates what's happening, somebody needs to communicate what's happening to that person. I'm sorry it's been so long, but what we're waiting for is this. Yeah? So if we all work with people, we get better outcomes rather than just leaving people just thinking, what the hell is happening? So I suppose it leaves it to the questions. I'm sorry it's been so rushed. Any questions for myself or Maria?
You bring up about patients helping them with what they need and what they want. Quite often people talk about for smoking.
Yeah.
On the EA, you can't leave the hospital premises, you can't smoke on hospital premises. Nicotine patch, it won't work.
No. So often you need to, say that to the person when you bring them in. If you're putting them under the act, then you need to let them know that. Look, sometimes I've broken the rules and I've taken them out because it diffuses the situation. It's not ideal because, as people will say, when you're not on shift, nobody else will do that. But you need to be honest with people, And that's the thing, we need to make a good decision why we're bringing them in. What are we going to get out of this?
My concern with taking them out on your own is that you're the one not liable. You're taking them off hospital premises.
Absolutely.
Breaking the rules.
Yeah, so I often do it with patients I know. So often when I get called out to patients and I know them, I'll ring them on the way, I'll text them, hey, it's just Kim, I see the ambulance is being called, and they'll text me back. They know they can't ring that phone, because it's always, and then I'll say, look, can you answer, I'm about to call. 9 times out of 10 they'll answer, because they know us now, but you need to have those discussions with people and let them know. Yeah, I've had police that have gone and kicked in doors, person's rang Lifeline, pissed, I'm suicidal. They've now gone to bed, they're asleep. But they're dragged in their jimmy jams. Have the conversation. You had this conversation with Lifeline, what's changed? So what I always say to my staff, if somebody's suicidal, you need to ask what's changed. What has changed that you're no longer suicidal? Because if you don't ask that question, you're not covered. You need to have a good explanation for what's changed. Yeah. But I agree. Smoking is one of the biggest thing of escalation in an ED. Yeah. Any other questions? Has that been helpful just to have a refresher around mental health? Sometimes I feel like I bore people because, you guys know you do it well. It's just sometimes, as I say, with our staff, have a refresher about an ECG. If you're going to ask ED staff to do something, then you need to refresh yourself on stuff as well. Yeah?
Awesome. So thank you, Kim, and also thank you to all our presenters this week. It's drawing things to a close now, and the good news is there's absolutely no formalities tonight at World Bar, so this is it from us. If you've been sitting there and thinking, I reckon I could get up there and present, or you know someone that you think could do it, please let us know. We'd love to hear from you. It's one of the hardest parts of the conference is trying to find, speakers that are able to appeal to our very diverse audience. So we find lots of presenters from past attendees. So please don't be shy, let us know, especially if you like Bali or Thailand. They're the 2 destinations that we're looking for presenters at the moment. Thanks to all of you. We've almost reached our goal of $10,000 to donate to Orange Sky. So parts of everyone's registration goes towards Orange Sky. For those who aren't aware of them, they provide laundry and meaningful conversations with the homeless people. So thank you very much to all of you. Big round of applause for your contribution there. Just a reminder, there isn't any food tonight at World Bar, so make sure you do fill your bellies up.